Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, and the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
So, Leslie, we are short Joe today because she is taking some time off to do Grandparents' Day. But you and I got to, well, you've known Dr. Flaherty for much longer than I have.
Time.
I got to meet him several months ago, and it was like a long lost brother. We kind of talked the same language. And so we had invited him to come on the show. And so we finally were able to get our schedules together. And so I am super excited. I've been looking forward to this for a while. So Dr. Flaherty, let me give a brief... Yeah, so Joe, a brief bio on you. You started off in St. Louis, right, as a physician, helped to develop a acute care, like an ACE program.
Yes, ACE unit in the hospital.
In the hospital in St. Louis.
Copied off of Cleveland Clinic's first ACE unit, just to give a shout out to
Yeah, for sure.
Palmer and the rest at the Cleveland Clinic.
And I met you several months ago at Medical City Plano here, and you have a delirium unit, which is how I became familiar with you because Leslie actually used to work with you at MCP. And so she was touting you long before I met you, and I was like, I got to meet this guy. And so this has been I've been looking forward to this conversation for a while. So can you give just a brief background on how you got into medicine, but more specifically like geriatric medicine and specifically to like the anti-delirium, anti-frailty component that you roll out in your units?
Okay, I'll try to be brief.
Yeah.
Interest in geriatrics. I grew up in a large family, grandparents, great aunts, uncles. So one of my great aunts got old, got to the nursing home back in the 1980s. And nursing homes back then were very scary places.
Yeah.
So got interested in trying to prevent people going into nursing homes, and then grandparents got old with dementia. And so got interested in the cognitive aspect of aging. So after med school, went to internal medicine residency and did a fellowship in geriatrics at St. Louis University also. And that fellowship really piqued my interest in all of cognitive, and not just dementia, but that delirium.
Yeah.
So I spent a lot of time in my 25 years at St. Louis University in the hospital, of course, teaching residents, teaching students, working with great nurses and therapists, and trying to prevent all the bad things that happen in a hospital.
Mm-hmm.
And about 8 years ago is when I decided to leave academics. Instead of trying to do everything, research and education, come down here and focus on hospital care of the frail, cognitively impaired elderly.
Yeah.
And so that's what I've been doing at Medical City Plano.
Did you see that there was a gap for that? Is that what led you into that? Like, hey, we're missing some things, and I want to go like hyper specialize in that.
Yes.
Okay.
Yes. So some time ago, probably my first interest in delirium was late 1990s. And that's when we developed our delirium unit at St. Louis University. But it never took off. But then around the country, people were becoming more and more interested in delirium. A group of us even started the American Delirium Society.
Oh, nice. Okay.
So that's still going strong. Every year they have meetings, and people like people at Vanderbilt and Johns Hopkins.
Yeah.
ICU delirium has just taken off.
Yeah.
I don't do much of that. I do more of just the regular inpatient. But the big gaps are, these big hospitals have all these older patients, and the cognitive issues as well as the physical function issues just kind of get pushed aside.
Yes.
And they go hand in hand.
Yep.
And so
It's one of the big, and the reason we met is because I was teaching actually at your hospital. Yeah, and it's one of the big things that we found too. It's like the hospitals are designed, I think appropriately so, if we think of it like in an area of focus, to fix this acute thing that's happened to us, whether it's a stroke or a heart attack or surgery or whatever. But they're really good at that piece of it and not understanding that, hey, this immobility piece of it can lead to all these things, including delirium. I think it happened to my own grandparents where, they were in a hospital and my parents were calling me going, hey, I think she's gonna have to move from independent living now to memory care because she's got a new diagnosis of dementia. So we have doctors, they're diagnosing dementia for a woman who was completely cognitive before going into the hospital. Like, it's not dementia, it's called delirium. And in large cases, if we can prevent that, yeah, it's reversible. That's right. Yeah, so fascinating. So I know, Leslie, you got to work with Dr. Flaherty personally, actually at in the delirium unit.
Yeah.
What kind of things did you see there? Like comparing that unit to like the other parts of the hospital.
Right. So the ACE unit actually came on after. So I got to work with you when you first got to Medical City Plano, and you were rolling out all this weird stuff about how to take care of geriatrics and I say weird because we just hadn't ever done it the way that you were looking at it. You were telling us that we could treat post-op hips of a certain age bracket with just Tylenol afterwards. That was a big deal. Yeah. Yes. And so I was a case manager on the ortho trauma unit. And I remember before you came along, we would have patients, seniors that would come out of the OR. They would go into post-op delirium. They would spend 5 days being, unfortunately, because the behavior was risky and their safety was at risk, we would have to sedate them or restrain them.
Thereby making it even worse.
It was so bad. And then not only that, but then we didn't get them up out of bed because they were a safety risk, right? Either the medicine or their behavior. And then I would have to send them to rehab and probably SNP, which is a lower level of care, which doesn't make sense, but that's the way the model is, right? And then as soon as you came on board, and you always are too humble for this, but I know the difference that you made. So when you came on board, I watched those same patients. You were consulted for them. Once we started kind of figuring out who you were and how to utilize your consultation, I started advocating for you. When these patients would come in, I would say, hey, is this a good, in rounds, I would say, hey, is this a good patient for Dr. Joe? And yes. Because the earlier I got you on boarded, they just didn't have complications. And hip replacements in the hospital, even traumatically, can go the very next day if they're medically ready.
You were instrumental because after several months of me being there, you helped me realize that we weren't many things. First, we weren't getting people to the OR within the recommended 24 hours.
Oh,
It was about 60%. So I met with the trauma surgeons who were kind of running the hip fracture service and some of the orthopedics. And they wanted to get up to the standard of 90 to 95% of people with hip fractures should have their hip fixed within 24 hours, maximum 48.
Yeah.
Because then once it's fixed, then you can get them off most of the pain meds and you can get them mobilized the very next day.
Yeah.
And so we got that number through a protocol,
Mm-hmm.
and we got it up to about 90, then 95%. And now kind of the standard has been, there's no questions asked.
It's 24
It's
hours.
just 24 hours. They come through the
That's
ER.
amazing.
Ortho's
Yeah.
called. We don't even call love cardiologists, but we don't call it anymore. We just take them to the OR because we know that if you wait day 2, day 3, then you're using more pain meds,
Yep.
immobile, more pain, constipation, urinary
Inflammation,
retention.
right?
All these things.
Yeah.
Yep.
You're having to stay like
Wow. So tell me about we talked about this a little bit before the show. I would imagine before instituting these kind of more protocols, for like nursing staff or whatever, that there's a pretty big cultural change when it's like, hey, this is how we normally did it. And now who's this Dr. Joe who's up on these floors? Now, wait a minute, we're not doing pain meds for narcotics for these folks. I would imagine there's a little bit of a shift for them to kind of learn why that works. But it's the results have been pretty profound. So like you catch on pretty fast, like, okay, this actually works. This is great. Yeah.
Sometimes they touch, you see one or two.
Yeah.
If you're a nurse, you see one or two times and you realize, hey, then we don't need to give them the IV morphine.
Yeah.
We can get them with just this routine Tylenol. So it doesn't take much.
Yeah.
I think nurses they're the most caring individuals in our society.
Yes.
Than mothers.
Yes.
And but in the hospitals, people don't give them the right, the skills, not the skills, the tools. They don't give them the tools to use to do what they really want to do.
Yeah.
You mentioned the culture of safety. They get bombarded by administration.
Oh yeah.
Don't get them out of bed because if they fall, it'll be a
Right.
red flag.
We got committees come
Well,
out of our
the
ears
amount-
about this stuff.
It
Yeah.
would take me an hour to do the paperwork if
Right.
someone fell. So it was
Reverse that. We haven't completely reversed the culture of safety, but we're getting better at it to say, hey, it's safer to get them up.
Yep.
And that's the beauty of our delirium unit is we've got eyes on everybody So you can get people out of bed to a chair or walking around because you got staff this far away from you. And that's the unfortunate thing, that the nurses aren't given that possibility in a hospital because their patients are all the way down the hall.
Well, and I think before your ACE unit, what we would do with those types of patients or that kind of experience with patients is we would hand them out, right? And so they'd all be spread out. You'd give one to a nurse because it would be overwhelming if you had all of them. But what it really did, and I never took care of them. I was the case manager, right? So I watched all the nurses. And I think what it did then is that you had these patients that needed a lot of care. And even just one of them, though, would take away from. But then once you put it together, then you start specializing in these patients in knowing how to take care of them. And the ortho trauma unit, those nurses were not afraid to mobilize patients. They were the best in the hospital. And so to see them kind of see your new orders about getting patients up even more regularly than they were used to, it only took you're right, it only took a few times, and then they were like, oh my gosh, this is amazing. Look at how well our patients are doing. And then the ACE unit, that changed everything because that place is busy.
Yeah.
Oh,
Yeah.
sorry.
It's a 5-bed unit.
Sorry.
And
Yeah.
I'll give you a brief story about the culture there. I'd been at the hospital for about a year and doing consults around the hospital. And I was seeing a lot of restraints, a lot of IV lorazepam to sedate people,
Yeah.
a lot of G tubes and NG tubes, a lot of negative outcomes from immobility and the confusion. So I presented some of the data to the administration. And they're like, wow, we didn't know we had this much restraints and all these bad outcomes and length of stay. And they said, well, yeah, what's your idea? I said, well, we have a delirium unit and we could implement one here. And so during our little presentation, the CEO, great guy, he's like, well, let's go find a place. And he cut the meeting short.
Love
We
it.
walked through the hospital and we found this old little
Oh, yeah. Yeah.
The old
I remember
ICU
the room.
and hadn't been used except for overflow.
Yep.
He's like, well, I think this is it.
Mm-hmm.
And within a month, the nurse director, God bless her soul, she made the decision just to do it without training any of the nurses. And the first couple months were just so hard as the nurses, like, none of the nurses want to come to this delirium unit, you can imagine.
Right.
And they took the float pool, who are some of the best nurses.
Yeah.
They can go in.
They can go anywhere.
First couple of months, we were doing in-services and talking. Well, long story short, after about 6 months after giving them the tools, which is, there's one called the TADA method, which I'll get to.
Yeah.
Interested. 6 months, unbeknownst to me, they had a huge party to celebrate the 6th month anniversary. They were so excited.
Oh, wow.
The delirium unit nurses.
That's
That's
awesome.
neat.
Okay. That's great.
That's
All right. So what's the TADA thing?
Okay, so imagine someone in their 80s
Yep.
come in and they either come in confused or they get real confused. And to them, it doesn't make sense that they're woken up in the middle of the night, blood draws, people touching them and moving them, yelled at them, not yelling at them, just talking to them, but it sounds like.
Right.
So we get real frustrated, and this frustration leads to the obvious term agitation.
Mm-hmm.
So agitation comes in many forms. One is, I just want to get out of bed. Okay. But it's 2 a.m.
Yeah.
Okay. What do you do for that? Keep them in bed. Don't let them get out. Call for restraint.
Call the doctor, right?
So the TADA method takes nurses through that. It's not easy by any means. So T stands for tolerate.
Okay.
So when people are restless and moving around, you have to at some level tolerate their behaviors. And the purpose of that is, if I tolerate your behavior, that'll give me clues to know why you're doing what you're doing.
Yeah.
And if it's 2 a.m, you're climbing out of bed and you're wiggling, guess what? Of course you have to pee.
Okay.
Okay.
Yeah.
And that's, it just dawns on them. Like, now I know why they're getting out. Or they're thirsty. Or they're just uncomfortable.
Mm-hmm.
Okay. So the next is anticipate. So we teach the nurses that, at 2 a.m, they're going to want to get up the bathroom. That's what they do all the time. Or they get out of bed for breakfast. You anticipate their usual behavior by talking to the family. And so you have to anticipate some of the problems. And then the DA is most important. It's don't agitate.
Don't make it worse. Yeah.
Don't agitate the agitation.
Yeah.
And what that means is we know part of the brain when you have this delirium, the prefrontal cortex kind of shuts down a little bit. So then that controls our emotions. But the amygdala section, the part of the brain with all the emotions, that just lights up. And so that frustration causes the amygdala to light up and you're getting frustrated and all that stuff. And so if you can imagine, if I agitate that brain, it's going to get more agitated.
Yep.
So we teach nurses, don't reorient. Don't tell people they're in the hospital. Don't tell them what to do. If anything, first don't talk. And usually people are yelling and cussing the patients. Or if you just sit there and watch them, they usually settle down after a while.
That's amazing to me because when I graduated in 2010, and gerontology was this new, they called it that in school anyways. I don't know how new it was, but it was this new field of nursing and for nurse practitioners. And we even had one of the first classes of gerontology, right, to learn this. And that is completely opposite
It is the opposite
of what we were taught.
Absolutely. Teach people to reorient. And I still hear nurses, I hear doctors, who's the president?
Yeah.
Give me my soda.
Right.
Yeah. It's important. So we've learned over the years, go to the happy part of the brain if someone's frustrated. So I almost always ask a person, what kind of work you did, what would you like to do?
Yes.
And in the heat of the moment, if you say, I heard you like to fish, I heard, yeah. Or you should hear this. I caught 4 fish on one day. And so it just changes the brain to action. And mostly, you'll love this. All of the stuff I learned from veteran nurses.
Oh, that's awesome.
And
Yes.
lots in memory care, but we translated it to the hospital.
Yep.
And these are just techniques. Like there's one nurse, Marianne DeMore, God love her, she was the best. She taught me, Flaherty, every action has meaning. You just have to figure out the meaning. So don't tell people that patients, if they're doing something, they're doing something wrong. That actually has meaning.
Do you know, as a case manager, if I ever got someone agitated, I used to ask what they did for a living. And if they were a CEO, a VP, something like that, I would talk to them differently because they needed to know the whole picture because they did that their whole life. So they needed detail because their job was to see the whole thing, and and they wanted to be in charge. So I also gave them something to be in charge of.
We tell our clinicians, it's like play, and caregivers, it's like play make believe. We see patients with dementia like in their assisted livings or whatever, and they are convinced that their son's coming to pick them up for lunch day. Awesome. Let's get your shoes on. Let's get you ready to go. And 5 minutes later, they've kind of forgotten about it. But if you push back and you reorient and go, nope, Jack's not coming today. He's coming tomorrow. All you've done is amplify that amygdala. You're right with the prefrontal cortex. It's another one of the reasons why when you do dual tasks, like if you ask them to walk and talk, you're now draining more of the prefrontal cortex. And so now it's more disorienting. They have more balance related issues because now the compensating part of their brain that was functioning is now having to do some new task. And so it just, all these things kind of tie together. The bottom line is, the DA don't agitate, make sure that you're kind of make believe with them. They're believing what it is and don't correct.
That's right.
Yeah.
With as much respect as you can.
Yeah.
But we're not treating them like little kids.
That's right.
We're going into their world.
Yeah.
That's right.
Their reality.
Their world is their reality.
Yeah.
So we got to change.
And they come a lot up until end stages. They do come around and realize, oh, okay, he's not coming today. Like Jack. And so, but in that moment, if you try to reorient, it's just not going to work. Yeah.
You had implemented too, I remember, some tips, just like you were getting the tools for nurses to take care of them with lines and Foleys and things like that used to be safety hazards, but we had to have them,
Yeah, so that's part of the culture change too, is we think we need all these, we call them tethers and attachments. And so one of our things in the delirium unit is when they arrive, we question every little attachment they have.
Okay.
So the Foley's like, no, get that out unless it's chronic, and take them to the toilet. Even IVs, if people had been stable, we'll either take the IV out, or if we need it, we'll cover it up, and this is an old nurse trick.
Hmm.
We put
A dummy.
decoy.
Well, I think a decoy is a better word.
A decoy IV in the other arm.
I had never heard of
Oh,
that.
no.
And it's just kind of
It just looks like
put a
it.
bunch of matty tape on there, and they'll play with that.
Mhm.
Again, this is the most confused of the confused people.
It was so
Oh,
smart,
man,
and it's so simple.
Yeah.
The old telemetry and the oxygen tubing.
Mhm.
Most of that is just part of the culture. We
Yep.
overuse it rather than have.
Well, I think of it from two angles. One, from the patient's perspective, that is even more disorienting, right? To have all these, I love the term tethers, to have all these tethers come in. But I think of it from, as a therapist, from the mobility culture of the hospital. If I, as a clinician, am walking into a room and they've got all these tethers, I'm like, and the patient says, I don't really feel like getting up today. You got it. We'll try again tomorrow. I just think of, Leslie knows me well enough. Like, I always think of, I try to remove as many points of friction as I possibly can, because the more barriers I have to overcome, the more it hurts that cultural change. So I think, to your point, like, if we remove the tethers, even from the clinical side of it, if I walk in a patient's clean and they got nothing coming out of them, it's much easier for me to transfer and walk them. And
Saved.
yeah,
You can spend twice as much time with that.
yeah.
And it was
that's
a
great.
relief as a nurse, because I was constantly trying to say, because it's dangerous to pull those kinds of things out, or they'd have all the leads on for cardiac monitoring, trying to get out of the bed, and, as often as they had
To
to.
jump forward, but I think we're going to have the day where there's non-touch vital signs.
Sure.
I've been looking at
That's
the
neat.
technology.
Oh, yeah.
That's neat.
So it can clearly do pulse. It can do breathing rate, do pulse ox. The next step is doing blood pressure just by looking at your face.
Whoa.
So it's
Okay.
It's that good.
Interesting.
Probably pretty soon, you'll just sit in front of a thing
It'll have all
in
your.
the hospital and zoom you, and it'll measure you and be like, okay, I'm fine.
Wow. Okay. So we talked about medications, and we talked about immobility within like the acute care hospital side of it. I don't know if there may be some good data on this. I don't know how to prioritize those things, but of like the top negative effects that you see, like with our normal acute care environment, what are the top things that you're like, hey, these things have to change? I know we kind of talked about a bunch of them, but if you had to pick like your top 2 or 3, what are the major things that, like, hey, if you're going to start introducing some sort of an ACE type program where it's paying more attention to your critically ill or more chronically ill geriatric patient, these few things we really have to dial in a little bit better. What would you say those are? Because you can't change 12, because that's a hard cultural change. But you can start with like 3, and then next quarter do another 3. So if you had like the top things, so what'd you say?
Things, there's the problem with the big hospitals is there's so many competing interests.
Yeah.
That old people don't win. The big cardiology procedures, orthopedics, GI. So if you're 85 and you're there for pneumonia, you're not going to get the attention that. So that's one thing I might change.
Okay.
And I think that's why the ACE units originally worked at Cleveland Clinic, and it's been replicated because they have their own floor. And so if you have everybody on the floor in their 80s with pneumonia and they're not having all these procedures, the whole staff on that floor can zone in and do the mobility that's necessary, do the discharge planning. And the model has shown you can reduce nursing home admission and get them back home sooner and better. So that would be my first thing. Is cohort.
Makes sense.
Yeah.
So you can kind of, and that's why our little delirium unit works, because we have control over
Yes.
the culture.
Yep. Well, you had buy-in too from the hospital CEO and the CNO.
Yeah.
So you'd say get a narrower distance or whatever, at least try to get some sort of a semi or at least closed off area, not closed off, but it's a segmented area of the hospital where you can kind of institute these things. Would you say it's hard? I know it's hard to like quantify to prioritize them. It feels like the most beneficial things are removing or reducing the amount of medications that can either sedate or affect cognitive issues, and at the same time making sure we're mobilizing patients earlier and often.
Yeah, if I had to choose, both are very, very important.
Yeah.
And you got to do it at the same time.
Yeah.
Like if I had to choose one, I'd choose the mobility.
Okay.
And I might start the mobility right from the beginning in the ER. So there are models of geriatric ERs. I know WashU in St. Louis is trying to do one, and now people can get credentialed in geriatric ERs, and they're getting better, but they're still on gurneys most of the time, and they're still long wait lists or long wait times. But I think that the better geriatric ER would be if someone came from home and they were walking, they should be evaluated sitting in a chair, unless they really need to lay down because they're losing blood or they're hypotension or something. But we need them out of bed in the ER. And we need to walk them to the bathroom in the ER. But you can't find a bathroom in an ER.
Right.
I had to pick a guy one time. You would have loved this. He was in the ER and he was agitated, calling 1-to-1, calling for drugs. And it was pretty clear as soon as I got there, all he wanted to do was go to the bathroom.
Right.
So we got him out of the bed. The nurses were yelling at me, "Oh, you can't do that." I said, "Just help me." I got him in there. And after he urinated, he's like, "Oh, thank you. Went back, went to sleep for 2 hours. And so the mobility is just the beginning.
Yep.
Then you can relax and start working on the medications.
Yep. I gotcha. You mentioned, or actually, I think you mentioned something about he had standing orders for mobility. What do those look like?
So it was just, post-op, you just automatic PT/OT.
Okay.
And if you did it right, if you had your surgery in the morning for hip surgery, that afternoon, you were sitting on the edge of the bed and even standing, especially if it was a partial hip hemiplasty.
Yeah.
And then we had standing orders for pain regimen, always routine Tylenol, like 650 TID, and then a little bit of Norco or something else, for uncontrolled pain, but not using the IV. And that's where we get the trouble is the ER they love it, the IV stuff, because it's quick. You don't have to get the patient to swallow it. People are laying down. Again, if you had people in the chair, they could swallow the pill lasts longer and all that stuff. And so there wasn't much standard orders. It was just early mobility.
It's more just making sure that we're paying attention, that we got to get these people up and moving.
It's a different way of doing things. Yeah.
That's it. I mean, and my other, I guess if my third one would be not allowing anyone to eat in bed, period.
I 100%
we're
agree.
on that page.
That is my thing. It's like, hey, we're at least getting you up 4 meals.
And not,
Yeah.
and they think sitting up, because you teach this a lot, that just sitting up is okay. And it's not. Actually, was that
It was
from
a
our
it was a
ICU nurse?
respiratory therapist.
Yeah,
I
that's
forget which
right.
hospital we were teaching at, but we had a few RTs in there. And they said there's actually a difference in sitting up, like having your bed sit you up versus sitting up in a hardback chair. It has something to do with the
core.
respiratory
Yeah.
muscles, where they've shown that they atrophy more if there's not a harder back surface for them to push against.
Yeah.
And so they always encourage out of bed and into like the recliner at least, so it's a little firmer.
We teach that.
And I had not heard that before. And all 3 of those RTs that were there, like, oh yeah, this is what we do here. Yeah.
What's almost better than getting to those chairs, which turn into recliners, which
Yes.
it's edge of the bed, and I'm doing that just the last year or so.
Yeah.
Because I got so frustrated I couldn't get people to the chair.
Okay.
Yeah.
So I said, let's just do edge of bed. And it's remarkable. Here's the most amazing thing. I have families take these videos, and I'll say, someone's just kind of hypoactive to her, and they're not just perking up. They're not perking up. I said, let's get the edge. As soon as you get to the edge of the bed, within a few seconds, they're like, then they open their eyes, and the families are just shocked. Like, they haven't opened their eyes in 3 days.
Yep.
And part of I learned from anesthesiology, there's the reticular activating system. Yep. And I learned from the therapist that if your head and your neck are touching, then the reticular activating system doesn't turn on. So you can't just bring the bed up. You have to actually get your back on.
You have to be engaged.
Sitting up, and then the lights.
Yeah. I'll tell you another thing that we run into too. And it's frequent with our more acutely ill folks, like the sicker folks. We see it out of hospitals. We also see it out of in assisted livings. And I train caregivers all the time on transfer training to help protect them and make it easier for the patients in these facilities. But one of the things I train them on is the very first thing. If you watch anybody go from sitting to standing, what's the first thing they do? They got to lean forward.
Yes. Oh.
So
I learned this a long time ago.
yeah, so they have to lean forward. And so what ends up happening is most of our patients that we're trying to transfer, they're like way back in the recliner or in the wheelchair or whatever. Yeah, and so you're having to lift them. And so what happens is when you have someone who's in a recliner for too long or in a hospital bed for too long, I liken it. It's probably not the exact right way to put this, but everyone understands it. It's like an alignment on your car. The car, you have the car going straight, but it's always veering to the right. So what happens is as these patients are laying in bed for too long, their body, their vestibular system gets used to that being straight up in the air. And so when you get them straight up in the air, they feel like they're tipped 45 degrees forward. And so now when you try to get them to lean forward to help us stand up, no, they fight you and they push back, right? And so there's that aspect of things too. And so that's another one of these benefits, side benefits of getting them sitting up on the edge of the bed, is we reduce the likelihood of them learning that this is straight up, but we're actually here.
See, I couldn't figure that out.
Yeah.
They do this all the time. So I fill out consults from the ICU only after they've been there for several days.
You got it.
And then the person gets transferred out to the hospitalist, but they've been 6-7 days on their back. And on like the edge of the bed, and the therapist says, well, we can't get them. They keep pushing back.
Right. They call it pusher syndrome. Well, yeah, they're pushing because they think this is falling forward. So they're going to push this way, which they're in their brain says going straight up in the air. Yeah. So if you can fix that, I have one quick story, and I want to ask you one more question. So I had this lady many years ago. She actually changed me forever with dementia care. And if I didn't know the doctor and the doctor hadn't personally called me, I was doing home health at the time. I don't know. I probably would have done evaluation only, which is what a lot of people, PTs do, because they can't, there's no return demonstration. There's no verbalization. So she said, hey, I have this lady who lives in the small assisted living. She's a teeny tiny lady. She's a 2-person transfer for the caregivers, and the caregivers are like, they don't know what else to do. It's really hard for them. Can you just please go see what you can do? I'm like, sure. So I get out there. This little lady, she's like 4'8". She probably weighs 75 pounds, right? She's teeny, but she's a sack of potatoes, right? She's got no tone. She's severe Alzheimer's, and doesn't speak a lick of English. Back then, I didn't speak any Spanish, so there was no like communication happening anyway. And so I called the doctor back. I'm like, listen, I can see what we can do. I said, there's clearly some postural issues. Maybe we can rely on, she was in her 80s. Maybe we can rely on some postural reflexes and try to teach her brain to do some things. And so I literally just started with her. We got her sitting up on the edge of the bed, obviously me supporting her. And we just started working on postural things to get her brain to remember. And it was fascinating. The second I got her to where she felt comfortable, I can't do it with the microphone, but the second I got her to feel comfortable putting her head on my shoulder. And if we would do that in a rocking motion, I'm in front of her. So I got to get it around her, right? I get her to put her head on my shoulder, and we're just rocking back and forth, right? I'm just trying to get her brain to remember. It's funny, not funny. It was really interesting. If I moved faster, like had her pulling towards me faster, her glutes, her hamstrings, and her quads would fire like she was trying to stand. I went, you got to be kidding me. It's still there. And so I used that. And so within about 30 days, I had her to a very minimal assist with one person. This was somebody who was a sack of potatoes who had no postural control whatsoever. But because the brain remembered those movement patterns, so takeaway for you is if the PTs can get them used to doing this motion again, a lot of times you can elicit, it's almost like a reflex, those muscles to fire again, and it makes the transfers easier.
Well, this is I'll put a plug in for ICU.
Yeah.
There's a website called ICU Delirium.
Oh, yeah.
ORG.
Okay.
It's out of Vanderbilt. And actually the original mobilizers were up in like Iowa. They were PT and OT did this amazing research study, and they mobilized people on ventilators. Yeah. On day one, you probably know this. Compared to usual care, day 6 or 7, and outcomes were dramatic.
Yes.
And so that started the snowball rolling, and everybody started. So people are mobilizing people.
I love it. We got to meet Kaylee Dayton out of Seattle, I think, Washington.
So she runs the program Awake and Walking out of Ohio. I think she's in Ohio, isn't she?
I thought it was for the West Coast, but
okay.
Amazing. Really,
she goes
really,
all over
really smart.
to implement these programs.
So there are several of us like out there. Like I teach in all these hospitals. I know you teach a lot. So there are a lot of us trying to move this slow moving industry to, hey, can we just please wake up? So my last question for you, because I know when we were emailing back and forth, you said, hey, one last point. I want to make sure that the people understand the connection between movement in the brain. So can you explain that?
Only by observation.
Yeah.
And then, of course, the research studies, and a lot of it's ICU delirium. Those visualization studies reduce delirium days by about half.
There you go.
So that triggers me is like, boy, you mobilize, the delirium gets better, so something must be happening.
Yes.
And my own experience, again, the delirium unit, we have a couple of the doctors, this funny cardiologist, we'll take people out of the cardiology floor that are just so confused, pulling on things, climbing out of bed. We bring them down there in the late afternoon, evening. He sees them the next day. He's like, what do you guys do? They're back
Completely
to
different. Yeah.
Isn't that amazing?
I
Yeah.
think it's just mobilizing, gets the reticular activating system turned on.
Yep.
So once you can be alert, you can start communicating, cooperating, and then you start moving.
Yeah. There are some cellular things that happen, and there's some vascular things that happen too. I know one of the things, I don't want to go too deep. So when you're immobilized for too long, there's a chronic inflammation that occurs that does cross what we know in the medical community as the blood-brain barrier, and that if that inflammation gets up into the brain, that creates a little more delirium there too. So that's part of the mobility piece of it. And I get all those things. I'm still convinced because the nervous system is a duplex. It's a two-way street, right? So we have afferent and efferent. So you have, when I tell my muscles to move, they move, right? That's the motor, that's the efferent. And then the sensory part of it is what we call afferent. So the nerves are communicating. It's a two-way street all the time, except for when you're not moving. The nervous system does not get the normal inputs. And there's got to be something else outside of just the cellular stuff that happens, or inflammation stuff that happens, where there's something we just don't pick up on, where when a body stops moving, the brain says, I'm not getting all the inputs I'm normally getting. And it just, I don't know if it goes to sleep, if it does something unique with that lack of input as well.
You're onto something. I wonder why restraints have been shown over and over to make delirium worse.
Yeah.
Is because if you can't move,
there's something to it. And it's like seeing pain on it. We can see structures and see inflammation on a scan, and we go, that's the structure that's broken, or that's the structure that's impaired, because we can see the inflammation around it, right? But you can't see pain signals. We can't see afferent and efferents, so we can't really see, but I'm convinced, the more I look at this, the more I work with patients, the more I study it, there's something to just the mere fact that we're not getting the sensory inputs into the brain that is breaking some connection there cognitively. So for what it's worth, there's my theory you can work on.
it makes sense.
Dude, I could talk to you for hours.
Yeah.
This has been a blast. This has been so much fun.
Thank you.
I know you. So you currently work at Medical City of Plano, and you are regional director for Envision. So
For geriatrics.
for geriatrics. Okay.
Large program.
Yeah.
One time we had up to 4 geriatricians, and
Okay.
one went on maternity leave with 3 little boys, so we were hoping she'll come back someday.
Gotcha.
Another guy had to move to Arlington, and so we've been going to different. I have a great new geriatrician, Dr. Abira Azam, up at Medical City McKinney.
Oh, okay.
She's doing great things with the trauma team up there.
Love that.
And then my other doctor with me is Dr. Anila,
Okay.
geriatrician. So we have 2 here, one of the.
And you guys are strictly acute care
Yeah.
focused, right?
Acute
Okay.
And consultants.
Got it.
So
Okay.
hospitalists or the trauma team, they call us. to
Ah,
come
nice.
And,
Okay.
not only prevent delirium, manage behaviors, but do some other geriatric stuff.
So Med City Plano, Frisco, Med City Plano and McKinney. Got it. Okay. Very good. Dr. Joe, it's been great to have you. Thank you so much for coming on. Yeah, this has been fun.